Hello friends, I welcome you all to this first session of a series of 3 talks which I have planned on non-pharmacologic management of diabetes. This is a very crucial topic and not much discussed in various conferences also. It is very unfortunate that 50% of the diabetes management which should otherwise be must be actually assigned to the non-pharmacologic management is never taken care of by any physician or any clinician practicing diabetes. So let us try to explore certain aspects which are important to understand this crucial arena of diabetes management. We will be covering non-pharmacologic management of diabetes under the following heads. Why it is important, what is the science behind the different components of the non-pharmacologic management of diabetes, and how it can be incorporated into your practice without much an effort so that it becomes a normal part of your way of dealing with your patients or counseling with your patients, and how much of it is needed for a particular patient. How to assess that particular aspect is very important in non-pharmacologic management. We should be talking relevant things to a relevant patient, which should be appropriate to that particular patient, and that is the art of medicine. We do all know, we definitely know that causes of diseases are mostly related to the way we are living today. The large portion sizes, even the stress busters are wrong. That is, smoking, alcohol are considered as stress busters after a busy day. Then unhealthy lifestyles start right from the childhood, and since our childhood we are exposed to an obesogenic environment which is ultimately carried as a part of our lives in our career growth and during our job assignments, and how do we perform in our day-to-day life. Reflections are seen everywhere, even when we grow up from this childhood. And the root cause of this obesogenic environment and obesity and overweight is the underlying biophysiological mechanisms involve lots of cytokine fat being deposited in wrong areas produces lots of chemokines and cytokines which are detrimental to health. Only one hormone, that is adiponectin, which is beneficial in terms of cardiovascular health, goes down, is underproduced in inflammatory conditions related to hypertension, atherogenic dyslipidemia, insulin resistance, or metabolic syndrome, and ultimately leads to prothrombotic, pro-inflammatory, and procoagulant milieu, which predisposes to cardiovascular diseases. We actually do not treat what is lying at the center, that is the lifestyle and interaction with the genetic codes we carry with us, which start from the intrauterine life. Not much is being actually done in this area in the center of this particular diagram, but most of the fireballs which we keep treating are at the periphery, which are related to the phenotypes which are clinically available to a clinician for diagnosis and recognition. And that is the reason you may extinguish few fireballs in the periphery, but since the fire is arising and burning at the center and the backyard everywhere around different organ systems, not much, not more than 20-30% benefits are achieved with any therapy related to the so-called phenotypes of the lifestyle disorders like diabetes, osteoporosis, hypertension, obesity, etc. So when we want to actually attack the central cause, and then it has to be something related to lifestyle, and management of those disorders will be actually practically escalated the moment we start focusing on lifestyle. So diabetes and cardiovascular disease are interrelated. We must not forget that 80% of the heart disease, stroke related to type 2 diabetes can be ascribed to unhealthy diets, physical inactivity, and obesity. The control of food supplies, food information, marketing, promotion of energy dense food, saturated versus unsaturated, all these things are actually involving lots of socio-political activity and commercial activity related to the socio-political environment around us, and much of that is beyond the scope of any clinician. But definitely we can explain our patients on dangers of obesity and overweight, which are related to different disorders and diseases which are easily recognizable and easily understood by our patients. So that should be the starting point. Non-communicable diseases are directly related to obesity. Everyone knows, whether you see the rows here, whether you see the columns, all these disorders which are actually killing the mankind, or which are actually rattling the mankind and different budgets, overwhelmed by the non-communicable disorders like heart disease, stroke, diabetes, cancer, chronic lung disease, and at the root cause of all of them, there is one thing common, and that is obesity. And when we want to really tackle the obesity, we will have to tackle the lifestyle and the patients suffering from obesity. The lifestyle management components must see not only the dietary management or physical activities related to calorie burning, but must also concentrate on stress management and sleep duration and quality of sleep also. This is very important, and we will be discussing little more on these things later in the slides. Let us first focus on diet and weight management, and what is the evidence related to the guidelines available to us way back in 2015. Even before that, in 2012 position statement, it was very clearly a lot of importance was given to lifestyle. It has always been given since the inception of the diabetes control programs. But as a heading of anti-hyperglycemic therapy, the lifestyle management is always prominently there, which we tend to forget. You pick up any guideline of any year, you will find. But then healthy diet and weight optimization are a few things which are not actually understood by the clinicians, because lots of jargon and lots of details which are being explained by various experts in diet and lifestyle management are so confusing that a primary care clinician finds it really difficult to understand and then to implement in their day-to-day practice. So I will try to simplify things for you guys here. Let us try to start with this first simple fact which should be brought home to every clinician, despite all the propaganda around us being done in the lay press, in electronic media, and everywhere in print media. We should actually, we very confidently tell our patients that dietary carbohydrate restriction is the main thing which can be easily done by any patient, can be explained by any clinician to their patients, and this has got very, very impressive results in n number of papers. The paper being mentioned here in this particular slide was a 2014 publication in which 12 points were highlighted with 100 references, more than 100 references in this particular paper, and they clearly showed that very low caloric diet with minimum carbohydrates, that is ketogenic diet, was having the maximum effect. Now the ketogenic diet is very difficult in vegetarian people where who do not consume non-veg food. That is because this is mostly an Atkins type of diet. Meat and all that are the rich source of proteins, but whatever the vegetarian world has got in terms of protein sources is having some component of carbohydrates always with them, like lentils, pulses, and nuts, etc. So you have to keep in mind that the low carbohydrate diet should be explained to your patient as the most crucial and powerful tool to cut down the kilograms in body, and this can be easily achieved by cutting down the carbohydrate dense food, as simple as that. Because acceptable macronutrient distribution, which has been taught to us since last 3 decades, shows this type of components acceptable. Now, I personally suggest my audience here today that to always see that carbohydrate content is not crossing beyond 50 or 55% in the diet you are recommending to your patient who is trying to reduce weight. So carbohydrate 50%, fat 30%, protein 20%, and protein or fat 25%, 25% and 50% carbohydrate is the easiest way to remember, and you can build up any diet around this that will be absolutely scientific, without any hitches, without any glitches. The patients will be, and will be acceptable to your patients also, whether vegetarian or whether non-vegetarian, because Atkins diet has been found to be most powerful, as I told you, in terms of weight loss, in terms of correction of lipids, in terms of improvements of HDL, and in terms of insulin sensitivity. And there are many papers like this particular one. Similarly, when it comes to low carbohydrate diet, it is found to be the best diet which can cut down HbA1c, glucose parameters, and of course correction of dyslipidemia, as I told you, with Atkins diet. So it matches, the low carbohydrate diet actually matches with the Atkins diet. So you can easily take care of your vegetarian patients who will be finding it very difficult to increase totally protein and abandoning carbohydrate totally from their meals. So these are the facts which are very easy to understand. Other important fact which you should easily be able to explain to your patients is the glycemic index of your diets. So low glycemic index is preferable, important, but then the glycemic load is also important. So the total quantum of the carbohydrate being consumed by your patient has to be a complex carbohydrate with very low glycemic index, preferably below 55. So if this type of diet is explained in terms of macronutrients to your patients, like full bran atta coupled with a liberal supply of green leafy vegetables being consumed together, it makes it absolutely low glycemic index and a low glycemic load type of combination. So authors clearly concluded in this particular paper, which was published way back in 2008, that overweight and obese people do get benefit in terms of lipids and body mass index, etc., by making the diets low glycemic index with low glycemic loads. So that brings the portion control into the focus. Small portions of everything in a particular diet being mixed together and being taken together. Another important term which you should also keep in mind is the macronutrient content of the diet. Rather than talking to the patients to your patients in terms of uh, carbohydrates, disaccharides, polysaccharides, it is absolutely something which will not be acceptable in clinical practice, because it will not be understood by your patients. So when we talk of Mediterranean diet, many of you will not be able to understand, but the use of oils like olive oil and nuts and uh, these things in diet is what is the closest to the Mediterranean diet. And in Mediterranean diet, it was found that addition of nuts and olive oil, despite producing weight gain to the patients, still gave benefits in terms of um, lipid parameters, in terms of glycemic parameters, and in terms of cardiovascular events over a period of time. So PREDMED was the trial which was done with Mediterranean type of diet, in which in low carbohydrate diet, nuts and olive oil were further added, and in fact, patients actually gained weight. So these are the things which it can be easily explained to your patients. So take home message for all clinicians is that low carbohydrate and Mediterranean diet beats low fat for weight loss and lipid changes at 2 years. This was absolutely clear-cut message coming out from many papers. This was one of them. And low carbohydrate diets, even with high saturated fat or without weight loss, do improve lipid and glycemic parameters. A paper which was published in 2015, the Freeman's paper, which was presented in, I think, in Stockholm, European Association of Diabetes conference. Now, whether these are all beneficial in terms of functionality of cardiovascular, just to bring home a point, I have placed this slide which tells you that flow mediated brachial artery dilatation after 6 months of lifestyle changes done gives lots of rosy picture and tells us that how endothelial dysfunction actually improves with low glycemic index and low carbohydrate diet. Inflammatory markers also go down when diet and exercise are implemented in therapeutics. Interleukin 6, interleukin 18, C-reactive protein and going down, and adiponectin improving, the good hormone improving. So therapeutic lifestyle changes, when we talk to our patients after finding out what they eat in terms of different meals in a day, we can easily chart out items for them and keeping in mind that we are allowing them 10% each of monosaturated and polyunsaturated fat. The total fat content is around 30% and carbohydrate around 50%. Fiber content has to be 2.5 to 3 grams per 100 calories a day, and which will be around 20 to 30 grams, and protein around 20 to 25%. In this particular manner, if you distribute the daily diets in 3 or 4 small meals which are placed 4 hours apart, starting from 9 a.m. and ending at 9 p.m. in the night, say for example 9 a.m. breakfast, 1 p.m. lunch, 5 p.m. snacking and 9 p.m. dinner, you can easily convince your patient that this can be easily achieved and should be done for the betterment of his own health and diabetes and all related parameters. Salt consumption has to be less than 5 grams per day, and calcium has to be 1 gram per day. And you have to keep in mind that water and fiber intake are not missed. Alcohol, moderate quantities. I will be explaining you why this can not be totally eliminated from many of our patients who will find it very difficult to get themselves see themselves not taking alcohol at all in on a particular day, or maybe the every day, the full week. How it can be allowed, I'll be explaining you. So dietary guidelines: eat at the same time every day, at least within 1 hour of regular time. This also has to be kept in mind. Eat about the same amount of carbohydrates, small portions, equal size, equally spaced, mixed meal, any seed oil. When the quantity control in terms of fat is being maintained, because the total fat content you have fixed up as 10% of poly and 10% of monounsaturated fat. So a lot of dietary ingredients are also having good quantity of fat. So if any seed oil which is being allowed as cooking oil is to be taken in terms of 2 or 3 teaspoons or tablespoons a day, then which seed oil should be consumed is a question which should not be even entertained at all. Any seed oil can be consumed to achieve dietary benefits which are expected from reducing the total quantum of the seed oil, in fact. So expected outcomes in uh, with medical nutrition therapy in type 1 diabetes is around 1% reduction of HbA1c, around 2% in type 2 diabetes, and A1c 1% reduction with type 2 diabetes of 4 year duration. That is lesser duration, the lesser improvements you can see, but then minimum you can easily see that it is as good as addition of one strong pill in the diabetes management equivalent to that. So LDL cholesterol goes down by 15 to 25 and HDL improves by around 6 to 8% with the help of non-pharmacological management. This is another fact you have to tell your patients in terms of scientific understanding of the facts which they should also be part of. Now, sugar alcohols being used as non-nutritive sweeteners must be allowed, but I am not very fond of these things, and they can be actually harmful in terms of inviting neurohormonal reflexes inside your intestines, when the taste buds are exposed to sweet taste in the mouth. That is a separate story, but still around 10% of the total calories can be consumed as even sucrose if the patient is not ready to totally stop taking sucrose in any form, because many of them will be requesting you to allow them half a teaspoon of chini in 1 cup of tea twice a day, which is fair enough, can be allowed. So, efficacy of diet in terms of obesity, diet therapy is efficacious in one patient when you treat them vigorously, 9 patients when they are treated. So, number needed to treat is 9 only to get benefit in one patient. And when you are reducing 400 calories per day, and at the same time the patient is burning 400 calories through exercise, you can easily expect 1 kilogram weight loss in coming week, within a week or so. Now, alcohol um, has got mixed publications, but the most scientific statement which can be made for alcohol usage is this: one drink of alcohol, which is around 30 to 35 ml of whiskey, rum, vodka, gin. So any alcohol liquor which is having 35 to 40% of alcohol in it can be consumed 30 to 35 ml as one drink per day, permissible to females, and two drinks per day as permissible to men. And many papers which have been published have shown a J type of association with this type of consumption of alcohol. That is, 1 to 2 drinks per day are actually beneficial to patients or to people, but more than 2 drinks, then the damage starts. Let us not forget that alcohol adds calories, 7 calories per gram. Let us also not forget that alcohol is a carcinogenic element. So, physical activity. Now, this is another important component which I would like to continue with now. And this is the real problem. The way we are living today is actually has no place for uh, even thinking of physical activity as important component of your life. Whereas in terms of scientific evidence, there is plethora of papers published from across the globe with different ethnicities that physical activity is beneficial. So here are the few: Malmo, Dashing, Nurses Health, Finnish, and Diabetes Prevention Study, which clearly showed that physical activity is very, very important. And these are the meta-analysis which clearly show that randomized controlled trials are very efficacious in terms of benefits of physical activity to our patients who adhere to it and who seriously take them in their day-to-day life. There are many papers from different parts of globe, as I told you before also. So lifestyle modification have been shown to be more beneficial than metformin in a 3-year study diabetes prevention program, which is very celebrated, well-known study. So 58% reduction in diabetes was achieved with lifestyle versus placebo, and metformin versus placebo, 31% reduction was achieved in diabetes prevention program. Look ahead trial was stopped earlier. Instead of 13 years, it was stopped at 9 years and wound up actually at 11 years or so. But then they found that intensive lifestyle intervention versus diabetes support and education program are working similarly in two groups of patients over a period of 9 to 11 years. This was the reason why the trial was stopped early, because cardiovascular benefits were not found to be different in these two groups. But we must not forget that initial 8 to 9% weight loss which was achieved was maintained throughout the period of 11 years till the study was labeled as concluded. And we must also not forget that around 5% or 6% of weight benefits in interventional lifestyle group was throughout maintained, and this has been seen in many other studies also. As when it comes to physical fitness, glycated hemoglobin, waist circumference, everything, the curves once separated, they remain separated over a period of 11 years. We should also not forget that all this was uh, seen in immediately in first 3 years and then at 5 years also, and gradual but consistent weight loss persisted throughout the trial of look ahead trial. Therefore, many of us who believe that look ahead trial was negative, I believe no, it was a positive trial in terms of glycemic parameters and lipid parameters, because both were seen to be improved with the intensive lifestyle intervention. We also should not forget that over a period of 9.6 years, we saw other benefits also, like biomarkers related to glucose and lipid improved. We know that liver fat reduced, sexual dysfunction improved, urinary continence, sleep apnea, depression, need for other diabetes medication were all seen to be favorable with intensive lifestyle intervention, improving quality of life, physical functioning, mobility, and renal benefits and eye benefits and reflexes, agility, everything was found to be better in the patients who were in the group of intensive lifestyle intervention, and all was achieved at much lesser a cost. So you just cannot ignore the benefits of exercise over a long-term period. Similarly, in intensive intervention case in Finnish diabetes prevention study, you can clearly see the lifestyle intervention were better, and they were gave us better results, and of course they were sustained over a period of, in Daching study also, over a period of 20 years, once the curve separated, the two groups remain separated in terms of events which were monitored in that particular trial. So the trial after trial, we have seen the once there are intervention related benefits, they remain persistent with patients for years and years together. The long-term impact of lifestyle studies are all favorable in terms of cardiovascular death and cumulative benefits achieved with the lifestyle interventions. Body composition, that is the total body fat and intra-abdominal fat, also improves with lifestyle modifications, intensive lifestyle modification. So these were the patients, post-menopausal women, who were taken up in this particular small study, who were randomized to moderate intensity exercise and versus just stretching for 1 year. So exercise now, what exercise, which one should be, this will be taken in the second module also in little detail, but you have to keep in mind that exercise has to be doable, should be feasible, should be enjoyable, sustainable, repeatable, safe, and as per the available resources to the patient. These things I will be talking in detail in the second module. So graded exercise testing for diabetic is very important, especially those who are age more than 35 years, type 2 diabetes for more than 10 years, type 1 diabetes of more than 15 years, having cardiovascular or coronary risk factors, presence of microvascular disease like neuropathy, retinopathy, nephropathy, presence of peripheral vascular disease. All these patients must be evaluated thoroughly before giving them a prescription for any type of exercise of any intensity. Any activity plan should keep in mind that accumulating 30 minutes of more per day is important. 150 to 200 calorie burning every day, most of the days, is very important at lower intensity to start with, and work up slowly, gradually upwards. Gap between sessions should not be more than 48 hours, because it has been proven with these studies that if the gap between two sessions is more than 48 hours, then benefits of the previous sessions are lost. Light stretching, that is heating up, or you can say gradually warming up and cooling down is very, very important. Some resistance type of exercises should always be done before and after an exercise session. Same intensity level for each session should be maintained. Activity diary helps a lot in adhering to the exercise programs, and healthcare team approach should be applied, who should be looking after the entire exercise program, not just a not just a diabetologist. So strength training has to be an important component, and anti-gravity exercises and anti-gravity yoga exercises are all good for bone health. Physical activity number needed to treat is 17 only for obesity and cardiovascular risk improvement. Increased physical activity without caloric restriction can reduce visceral adipose tissue and insulin resistance. Let us not forget that. So even if you are not restricting calories, your insulin resistance will improve. Physical activity with caloric restriction will give you more weight loss, keeping your muscles and bones intact, because otherwise you will be losing muscles and bone also if you are losing weight without exercising. Resistant training may be particularly beneficial in modifying body composition. This is related to mainly bones, muscles, and joint flexibility. Similarly, increase in plasma HDL cholesterol levels and reduction in triglycerides and BP are greater with combination of dietary restriction and physical exercise. So, along with diet plus weight management, stress must also be addressed too. A psychophysiological phenomena is a composite of intellectual, behavioral, metabolic, immune, and other physiological responses to a stressor of endogenous or exogenous origins. The stressors may involve thoughts and feelings, or maybe perceived threat or some other conditions such as cold. The response generally serves a protective adaptive functions. So types of stressors can be related to career, injury, accident, emotions, emotional setbacks, physical, competitive sports, etc. All can cause stress, and of course environmental stress like we have COVID right now. Coping activities must be part of your counseling with your patients. Try to bring home some consolation, some empathy in your talks. Tell them about relaxation techniques, exercise, and of course, develop some action plan. Give them something to do. That is very important. You should be telling them what not to eat when they are trying to burst their stress, because stress busters sometimes eating food, munching snacks, having a glass of wine, or smoking a cigarette sometimes is taken as a stress buster by many of our patients, which should be strongly discouraged and counseled by the practitioner. 7 to 8 hours of sleep is very important. I'll be taking sleep separately also in my module 3 of this non-pharmacologic therapy. Yoga and of course exercise, biofeedback, and all these things are important. Cigarette smoking and cessation must be the target in every smoker for any primary care doctor. So you have to keep in mind that when you prescribe exercise and lifestyle modifications in non-pharmacologic therapy, you are giving them anthropometric, physiologic, metabolic, physiologic, psychologic, and behavioral and quality of life benefits, which are absolutely not available when you write a prescription for them. Writing down a prescription, a drug to treat diabetes, absolutely has no benefit in terms of so many things mentioned here in terms of quality of life and related. You can call them also pleiotropic benefits of lifestyle and diet therapy. So, lifestyle versus drug, you can summarize like this: drugs absolutely cannot tackle the root cause. They do affect diabetes risk, but cannot as potently do that as potently as the lifestyle changes will do. The effects are sustainable. As soon as you stop drugs, the effects are gone. Here we have seen for years together effects remain sustainable, and there are all halo effects which I just mentioned in the previous slide, long-term benefits are proven in terms of lifestyle and modifications related to diet and lifestyle. So quality adjusted life years are absolutely unparalleled, coming better with lifestyle and diet modification in terms of reducing mortality in all these disorders, including diabetes, heart attacks, gallbladder disease, cancers, stroke, and overall mortality. So, quality adjusted life years are added to the longevity of your life when you are actually prescribing with full confidence and with full power of whatever you know in terms of knowledge and whatever conviction level you have. If you prescribe the non-pharmacologic therapy to your patients, you will be adding many quality years to their lives, and instead of just adding a few additional years without any good quality of living. So this I'm concluding this session one related to non-pharmacologic therapy. I will request you all to come back to this channel and try to find out the module 2 and module 3 also, which I will be posting very soon for the benefits of all my medical colleagues. Thank you very much.